Audio Jungle.
Hello, I'm Penny Tuffin. I'm an Advanced Practice Pharmacist in Palliative Care, and today we're going to be talking about pain management in palliative care.
Audio Jungle.
Good pain management requires an accurate and detailed assessment of the pain and what it means to that patient. We need to have pain as a coordinated part of their care plan so that it fits with everything else that's happening, because pain will change as patients' disease changes, but also as their treatments vary as well. We need to understand the different types of pain and the type of management that we will need to use to manage those pains. We also need to have a really good knowledge about the analgesics so that we can choose the most appropriate analgesic in the right dose by the right route for each individual patient. And we must always have ongoing assessment. Not only does the pain change, but we also need to make sure that the medication or other modalities of management we've initiated are actually doing what we expected them to do. For this presentation, I'm going to be mainly concentrating on the types of pain and in particular upon the medications that can be used to manage it. Pain can generally be classified into acute or chronic pain. Acute pain is abrupt in onset, it comes on very quickly and normally only lasts for a short period of time. The general definition suggests that acute pain will last for as long as the injury is present, and we normally consider that to be less than 3 months. When we have someone with acute pain, we have associated signs and symptoms of that, so we can see that the patient is in pain. Their heart rate goes up, they become pale and they sweat. With chronic or persistent pain, the response of people can be quite different. Their body starts to behave differently in response to a pain that is ongoing. And so generally chronic pain is classified as pain that continues beyond the natural healing of the injury. In people with palliative care needs, we actually see both types of pain. So they'll have a chronic feature of their pain, which is ongoing, but often increasing, which is different to a person with general chronic pain. So as their disease progresses, their pain may increase. But we also might have flares of their pain, acute flares due to treatments that they may be undergoing, surgery, radiotherapy, which may modify their pain for a short period of time. So our assessment needs to be very clear in working out whether this is an ongoing pain for this person or whether this is an acute pain that we expect to resolve. When we're classifying pain, we need to consider all these different elements. So it may be a background pain that is there most of the time and doesn't change an awful lot. It may be an end of dose pain, so we may find that the medications we're using last for a certain period of time and then they have pain before they get the next dose. So we need to be very careful when we're asking people about their pain, about asking whether the medication we use works, but also how long it lasts so that we can choose an appropriate dosing interval of each medication for the person. We may have breakthrough pain. So breakthrough pain is a type of pain that will happen. The patient generally through most of the day, their pain is fairly well managed, but they may have some flares of pain during the day. These may be spontaneous, so there may not be a particular trigger that they can identify. They may have just been sitting in their chair and suddenly their pain has got worse, or there may be incident pain. So situations that are brought on by an activity. So for instance, when they get up to have their shower, that extra movement, that extra exertion actually causes more pain. So that's something that's going to be predictable, and we can suggest that they have medication prior to that activity. We also classify pain as either being nociceptive or neuropathic. So nociceptive pain is the type of pain that is picked up at the end of your nerves and the message is sent up to your brain. So what happens is you have an injury, your nerve endings respond to that and send messages to your brain saying there is pain in this area of your body. We classify nociceptive pain into either somatic or into visceral pain. Somatic pain is peripheral pain on your skin, maybe in your bones or muscle. And so generally people are able to point directly to where it hurts, their shoulder or their elbow, for instance. We also have visceral pain, which is much deeper pain, so pain in their organs. So a patient may actually use their whole hand to put on a part of their body that hurts. And the reason they're doing that is that all the nerves that are going to that part of their body are sending messages to the brain that there's something wrong. We then have neuropathic pain, which is also called nerve pain, and this is where the actual nerve that's sending messages to the brain is damaged. And it may be damaged because of inflammation, the site around has been injured and so therefore is inflamed and pushing on the nerve. The nerve itself may be cut or bruised or damaged in some way. And so then it's sending unusual messages to the brain that the patient will describe quite differently. So they might talk about a numbness, they might talk about a shooting pain or a burning pain. When we're talking about managing pain, we must look at non-pharmacological ways of managing pain initially. So we want to try and address the causes or underlying exacerbating factors. So we will look at things like providing surgery if we can, giving chemotherapy to treat a tumour and reduce the size of it to try and modify the pain. We may also try environmental type modifications, so actually changing the way that the patient manages their pain, how they think about their pain. And we also have to look at associated symptoms. So it may be that the patient is very anxious, and so therefore by helping them to moderate their anxiety, they may not be expressing as much physical pain. So the non-pharmacological techniques that we'll use very readily and very commonly, there are physical techniques where we may use a nerve block. We may use physiotherapy to get muscles moving that are tight. Or we may use acupuncture. So all of these modalities and lots of others can be used as physical ways of looking at pain without having to use medication. We also very much will look at psychological techniques and often get a psychologist involved in helping the patient to moderate the way that they think about their pain and live with their pain. And that will generally involve educating them about their pain, educating them about ways they can manage their life with their pain. We may use things like meditation or distraction to try and help modify the way they're thinking about their pain. And of course, things like social supports and people actually providing support to them will also be very beneficial. When we're talking about analgesic use, there's some basic principles that we need to think about. So we need to think about the analgesic medication that we're choosing. We need to look at multimodal analgesia, so using different medications that work in different ways to help moderate the pain. We need to choose an appropriate route, something that's going to be absorbed into the patient's body and work well for them. And we need to make sure we're using an appropriate dose. So when we're looking at analgesic choice, we consider the WHO analgesic ladder. So this ladder was produced in the 1980s to specifically look at managing cancer pain. It hasn't changed very much over that 30 years, and it has been proven to be a way that will moderate the majority of cancer pain. It's a stepwise approach. It considers using oral analgesics as its main modality, and it's a stepwise way of moving up in a practical and logical manner to moderate pain as it gets worse. So this slide shows you the WHO analgesic ladder, and as you can see, we start with step 1. So we start with non-opioid analgesics, so things like paracetamol and non-steroidals, to see if we can manage pain with those. If they aren't sufficient, then we will move up to weak opioids, so things like codeine or buprenorphine. If those opioids aren't working, then we will switch up to a strong opioid such as morphine or oxycodone or hydromorphone, all the while still keeping the non-opioids going. We also may need to use adjuvant medication. So if the patient has neuropathic pain, our medications such as non-steroidals and paracetamol and opioids are not so effective in treating that pain. And so we may need to use medication specifically tailored at treating neuropathic pain. Generally, when this WHO analgesic ladder was produced, it was produced as a way also of trying to get opioids into third world countries. And so therefore the step 2 of the analgesic ladder was very important. However, for most of us working in Western Australia, we will generally skip the weak opioids and move straight from step 1 to step 3. So there's lots of medications we can use to provide analgesia. Paracetamol, non-steroidal anti-inflammatory drugs, corticosteroids for their anti-inflammatory effect, opioids, tricyclic antidepressants, and SNRIs, serotonin noradrenaline reuptake inhibitors, and anticonvulsants, all for neuropathic pain. We may use ketamine for neuropathic pain or difficult to treat pain, and clonidine is also another medication that may be used. However, generally in palliative care, opioids are considered the mainstay of our analgesic medication. We know they're very effective for treating cancer pain, and studies have shown that 95% of patients with moderate to severe pain will have their pain managed within 2 weeks with the use of opioids. It doesn't matter whether we look at morphine, oxycodone, fentanyl, buprenorphine, they all can be titrated to be equally efficacious in managing cancer pain. And generally the studies will show us that they reduce pain by a 3-point margin on the 0 to 10 scale, so result in a significant decrease in pain. We do know, however, that adverse events are very common with opioids, and we need to monitor these all the time and provide some sort of relief for the side effects. For instance, if it's constipation, then we need to provide laxatives and good education for people on how to moderate constipation. However, what we do find generally in cancer pain is that although patients express they have adverse effects, they would actually much prefer to be taking the medication than to be in pain. However, there are people who also won't take their opioid analgesics because of the adverse effects. So we need to be very carefully monitoring, explaining, and treating adverse events. When we're talking about opioid management, we also need to be very mindful that opioids can be misused in our society, and so therefore we need to give good explanation to people about why they're taking opioids, that they should only be used for their pain, not for other people using their medication. We need to make sure they know how to store them safely. So foundations for opioid use, as I've said, they are the mainstay generally in palliative care. No one particular opioid is superior to any others, so it is a matter of choosing the most appropriate opioid for that person, and if that opioid after a good trial hasn't worked, then we will switch to using a different opioid. So for instance, if we have a patient who has renal dysfunction, we may choose to use fentanyl rather than using morphine because we know that it is less likely to accumulate because it doesn't have active metabolites. If patients are prone to constipation, we may choose an oxycodone-naloxone combination because we know that the rate of constipation with that medication will be lower. Doesn't mean that the patient won't have constipation, however, because patients with palliative care needs have a lot of reasons for having constipation, and we have another video that talks specifically about managing constipation in people with palliative care needs. We need to be very mindful when we're managing pain with opioids that different people respond very differently. So we must always start at a low dose and titrate up. Even if the person has extreme pain, we don't start at a high dose of opioid. We start at a low dose and we provide ongoing assessment and ongoing modification of their dose or their opioid to make sure that we are getting on top of their pain very quickly. Multimodal analgesia is the name given to the situation where we're using several different medications to try and manage the pain. And this is done because we know by using different medications that work in different ways, we can get much more effective pain relief. Often it is more than just additive, and we actually get a synergistic effect and get a much better pain relief for the patient by using different drugs. It is also generally much safer because it means that we can use a lower dose of each medication and therefore have less side effects. And that's particularly pertinent to opioids. By being able to keep the dose a bit lower by using other medications, we're actually modifying the amount of adverse effects that a person will have. So this diagram just gives a little bit of an indication about how the different modalities we're using to treat pain work at different parts of our peripheral and central nervous system, and therefore by using them each at using medications that work at different places, we can therefore moderate the pain at various different ways as it's progressing up from our peripheral to our central nervous system to our brain. And so this is just a very quick schematic diagram just to give some indication of where these different modalities are working. Our next major underpinning is that we must choose an appropriate route for the person. So our first choice is always oral. Oral medication mean that the patient has control over what they're doing. They're putting the medication in their mouth and they know what they're putting in. These medications are generally more readily available. They're available on the PBS. And so we always choose oral if possible, but not all our patients are going to be able to manage with oral medication, and there are some difficulties with using oral medications. The patient may not be able to swallow, they may not be able to absorb medication orally because of their disease. So we have other routes available to us. The intravenous route is the fastest route for patients to get an effect from medications, and generally we don't use the intravenous route very much in palliative care, but we must always consider, if we have someone in extreme pain for instance, that it might be absolutely the most appropriate route to use. Generally, the other three routes that we will use far more commonly are the subcutaneous, the transdermal and the sublingual route. The subcutaneous is less invasive than the intravenous route, and I'll talk a little bit more about that. The transdermal route is particularly good when a patient can't swallow or they perhaps don't remember to take their medication so easily. And sublingual is available for some medications. They'll be absorbed sublingually or buccally, and so it makes it easier if the patient can't swallow. There is generally no indication at all for using medications by the intramuscular route. Subcutaneous, I said, is a good alternative for patients who can't have oral medications. It's less invasive and there's far less infection risk than giving medications intravenously. We will generally always start in pain management, we'll start by giving the medications on a when needed basis, PRN basis, and then when we work out what amount of opioid they require, we may change this to an infusion so they've got an ongoing background of pain relief. There's many medications we use by this route that aren't licensed to be given subcutaneously, and so we need to be very mindful of this. However, morphine and hydromorphone are licensed for subcutaneous administration. The transdermal route can be very convenient if patients can't swallow. We must be very mindful, though, that it takes a long time for medications to be absorbed by the transdermal route. So when we put a fentanyl patch on, it will take up to 24 hours as a general basis for the medication to reach a good effect in the person's body. So if we've got somebody whose pain is very strong, we're going to want to use other medications as that fentanyl patch is reaching its full analgesic potential. Buprenorphine patches take even longer to reach their peak effect, so up to 60 hours. So we're going to have a couple of days where we're going to have to be using other medications while that drug gets into the person's system. We need to remember that the potency of all the medications is quite different, and use our conversions if we are going to start a fentanyl or buprenorphine patch. And patches are never our first line agent, so we will generally try to titrate the person's analgesic needs with an oral medication if at all possible, or subcutaneous morphine, work out roughly what the patient's opioid requirements are, and then work out what the appropriate size patch will be to start the person on. If the pain is fluctuating rapidly from day to day, then a patch again is not going to be the ideal medication to use, because we're always going to be chasing our tail. We'll never quite get on top of pain. So we titrate, as I said, with a different opioid, and once we've reached a stable dose or their pain is stabilised, then we will switch to a patch. The sublingual route is very useful for patients who aren't able to absorb orally as well as not able to swallow orally. And buprenorphine tends to be our analgesic that we will use in that situation. We need to be very mindful if we're using buprenorphine that it takes a long time to have an effect and also has a long half-life. So it's quite different to other opioids that we use. Sublingual buprenorphine will take about 90 minutes as a median time to effect, and it will last for about 8 hours. The fentanyl sublingual, however, is quite different and works very quickly. We would expect to have some effect within about 10 minutes and good analgesic effect within about 20 minutes. It does, however, only work for about an hour and a half to 2 hours. So this is where we need to be thinking very carefully about what medication we're going to choose and what effect we're trying to get and how quickly. So once we've chosen a medication and we've chosen what route is going to be most manageable and appropriate for the patient, we need to determine what dose is going to be safe and effective. For most opioids, the dose is going to be dependent upon the patient's age and upon their organ function. So if they are older, they will generally need a smaller dose of opioid. If their organs aren't working so well, then we also may need to reduce the dose and also increase the dosing interval. So always we start at a low dose and we titrate that up by monitoring the patient's pain, monitoring how they're saying that their pain is being affected by the dose, and also looking for adverse effects. The frequency of dose will generally depend upon the pharmacokinetics of the drug. So what we're going to look at is how long we expect a drug to work for. So if we're starting with something like morphine, we expect morphine to work for about 4 to 5 hours. So we would expect that if we give a dose to a patient, they would get good analgesic effect for about 4 to 5 hours. If we find that it's only working for about an hour, that means we probably need a bigger dose. So generally the foundations of opioid prescribing are that we will give a regular dose of opioid at a regular interval based upon what we know to be the length of time that medication works for. We will always use oral if at all possible. We will also always provide breakthrough medication. So we'll have a background opioid going constantly, but we will also provide another medication to use for top-ups for breakthrough pain. And we generally choose 1/6 of the background dose. We work out how much they're needing as a background, divide that by 6, and that becomes their PRN dose. We also give advice that if they're needing several breakthrough doses during the day, they need to contact their health professional, because it may mean that their background dose needs to be increased to manage their pain more effectively. Whenever we're prescribing an opioid, we need to make sure that we have also prescribed a laxative, because all opioids are constipating to varying degrees, and we also need to prescribe an antiemetic, because we expect over half the patients we prescribe an opioid for to have some nausea and vomiting, particularly when they're starting an opioid or when their dose is increased. And we need to always titrate carefully, and we need to always explain why we're doing this and how we're doing this to the patient, and make sure they understand about the side effects of morphine, what to do if they have them, and also to know not to increase their dose without the advice of a health professional. And we need to make sure they know to store these medications safely. We do know within our society that there is overuse of opioids, and we also know the rate of increasing misuse of opioids from medications that have been prescribed to people. So that may mean that people inadvertently take more than they're meant to for various different reasons, or it may mean that the medications are being used by someone they haven't been prescribed for. So when we're prescribing opioids, we need to provide information to patients so that they're able to take them safely, but also get a really good effect from them. We do see that sometimes large doses are used initially, and that's not going to be best practice. We must always start with small initial doses and increase as needed for the person's pain. We need to also be very mindful of not increasing the dose too rapidly. Generally, if we're using, for instance, a slow-release oral opioid, we shouldn't increase the dose of that any more frequently than every 2 to 3 days, because they won't have reached the peak effect of that drug until that time. We need to make sure that it is physical pain that an opioid will work for, that we're prescribing this opioid for. People who have anxiety or depression or other psychological distress because of their situation, we need to explain that opioids are not going to help with that, and that other modalities and other ways of treating that are better. We need to make sure that the medication is still working. So patients may find that as they progress through their disease, they may have times where their pain actually decreases, and we should be always monitoring and be ready to decrease the dose when that's possible. And it's quite common that patients may, because of flares in pain, because of certain situations, their pain may need to go, their analgesia doses may need to go up, but then we may need to bring them down again. And we also need to explain to families as well about how the opioids are being used and how pain is being managed in the patient, because families don't like to see their family member in pain, and they don't like to see them distressed. So explaining to the patient's family is really important to make sure that they don't give too much medication and make the person extra drowsy or extra confused, when really a different way of managing the situation would have been more appropriate. We do have a statewide opioid analgesic conversion chart, and the Cancer Council has a video explaining how to use this in detail, and it's important that we understand the different potency of the different opioids that we might be choosing and feel confident in converting from one opioid to another. So the basic principles of pain management in palliative care are that we want to achieve good analgesia for people as quickly and as simply as possible. It's going to be rare that we're going to be able to completely get rid of anyone's pain, but we need to have the pain to a level that it's manageable, and so that they can have as good a quality of life as is possible without their pain interfering with that. We need to consider things like using the WHO analgesic ladder as a logical way of increasing analgesia. We need to be very careful when we select which opioid we think is the most appropriate for that person. But if that doesn't work out quite as we'd planned, then know that we do have other opioids that we can then change to, and know how to change that safely. We need to think about which route of administration is going to be most suitable for the person, and that may change as their disease changes. We need to make sure we always start at a low dose. We titrate carefully with consideration to how the patient's describing their pain and how their disease might be progressing. And we might need to change to a different opioid. We may need to add in a different analgesic agent. Thank you for watching the video today on pain management in palliative care.
Audio Jungle. Audio Jungle.